So this is going to be just a summary of a case that we attended with some learning points around the video-laryngoscope, which I think can be quite useful for the bigger team, but also just useful if you are thinking about getting a video-laryngoscope or are using one in your practice. I'm going to just move through some of the information about the case, so about the patient, and then chat about some of the challenges that were experienced, how we moved through pre-oxygenation and optimizing the patient for the best possible outcome for the intubation. And then we'll watch the video and walk through the video with some comments about how the video-laryngoscope was used, some of the mistakes and errors that occurred as I inserted it into the patient's airway, and then some of the lessons that I'm going to take away that I think would probably be useful for most people using video-laryngoscope, especially if it's not one of the more advanced devices like a CMAC or a GlideScope. So just a little bit of background about the patient. The patient was a 43-year-old female patient who presented to quite a rural facility with signs of rapid onset Guillain-Barré. The patient had sort of an ascending paralysis and had over the last 24 hours gone from weakness in the feet, weakness in the ankles and elbows quite rapidly towards respiratory distress and then obtundation just from a CO2 and ventilation problem. So the patient was found seated upright in an emergency department in sort of the resus area. The patient was unresponsive when we first came to her. Level of consciousness, she was sitting with a GCS of 7. She was scoring 4 for localizing pain, but not able to move her limbs, was sort of grimacing to pain and moving her head in the direction of the pain. She was scoring a 1 or 2 for eyes and a 1 for verbal, not really making much noise. 1 or 2, depending on where we found her. She was quite large, so we noticed immediately her BMI was definitely increased. We were sitting at about 130 to 140 kilograms. The reported weight was 126 kilograms, but I don't really know how they managed to weigh the patient. So she was really short. She had quite a short neck, obviously quite a lot of adipose tissue around the neck. Her chest was quite large. She had quite heavy breasts and a relatively large abdomen. There was some ascites as well. And then some pitting edema in the feet, pretibial and pedal edema. She was breathing with quite a lot of distress, accessory muscle use really only in the shoulders. Apically, she was moving a bit of air into the bases of the lungs. Almost no air entry was audible. She had very decreased air entry, moving probably about a quarter of the tidal volume that would be reasonable for her, and working very hard to do that. A little bit of nasal flaring, and she was clearly obtunded. She was saturating okay at the time of assessment, sitting with sats of 94%, but on a 100% non-rebreather mask running at 12 liters per minute, so really pushing the oxygen. And then in terms of blood gas, our very first blood gas that we had a look at, which had been done at about 6:30 that afternoon, and we were there at about 8:30 in the evening. The 6:30 blood gas showed pretty normal parameters, slightly hypocapnic, but nothing really to be worried about. The next blood gas showed a CO2 of 84, so we were definitely losing the battle with this patient. The team in the ED were not really equipped to manage the airway of a patient with such difficulty. Also didn't have a video-laryngoscope available due to the nature of the environment. And were not really too worried about the blood gas because they hadn't really done one until we were arriving. So hadn't really noticed that she was losing ventilation ability. So it was quite quickly made, the decision was made that we were going to intubate this patient, but everyone in the room was quite anxious about intubating this patient just based on her size, and then based on some of the acidosis, the PCO2 that was quite high, and the fact that we were going to have to get it right the first time, and didn't really have much functional residual capacity in terms of how she was going to be able to cope during an intubation. So we made a lot of decisions quite quickly and decided that probably the thing that was going to keep her alive the longest and that was going to help us get a safe intubation was going to be getting her onto NIV and starting her on some positive pressure ventilation, because the way she was ventilating, she wasn't going to last very long and her pH was dropping quite rapidly. I think we were sitting at a 7.1 with that PCO2 of 84. So immediately got a BVM mask out and popped her onto the vent with a pressure-controlled SIMV. with the idea that although she was currently breathing, she was really breathing quite shallow and she wasn't really maintaining super well. And we were intending to intubate her relatively soon, and wanted to ventilate her during that period of time while we were both setting up the intubation, but also in the period of time following the paralytic, just because her functional residual capacity was so low. And we ended up getting her quite well settled onto NIV. Obviously, she was quite obtunded. I was expecting that she was going to wake up and become a little combative, because once we got the ventilation sorted, her CO2 should drop and that level of obtundation should decrease, but that didn't actually end up happening. So got her onto ventilation, initially set settings quite high based on what we thought her chest compliance was going to be like, and noticed quite high tidal volume. So immediately titrated that back and managed to get end tidals up to about 55 with sats that eventually ended up settling at about 98 with an FiO2 of 100% and a PEEP of between 8 and 10. We initially started at 10 and then titrated back to 8, just so that we limited the inflation of her stomach at all. She managed really nicely. We didn't do a non-proctored NIV, so that means once we started NIV, I was stuck behind the patient's head, holding the NIV mask on and holding a really good jaw thrust, because she was not able to manage her own secretions and her own airway at that point. And we were quite worried that if we were introducing positive pressure, there might be some response in terms of vomiting or at least regurgitation. And there was this worry that we were going to end up with an airway that was unprotected if we didn't have someone standing at the airway continuously watching. We had suction ready just to the left of me when I was holding the airway in place, and entitled CO2 obviously on and SATS probe on. At this point, we decided to set up for intubation. So while I was doing NIV, my partner was busy setting up all the equipment. We used a basic checklist that ran us through an optimization of oxygenation approach. We had already in the head-up position. We already had NIV going with PEEP going. And we decided to put a nasal cannula on under the NIV mask, just so that we could get that APOX during the intubation attempt for later. We then sort of optimized her perfusion, which had settled really nicely considering where she was when we got to her. She initially had a blood pressure of 184 over 100. And once her oxygenation and ventilation started to get sorted out, we managed to get a blood pressure sort of within normal ranges, around 130 over about 80. That did trigger a thought in our minds that there was the potential she might drop blood pressure if we gave a lot of medications, but we decided that it was not an appropriate time for this patient to start adrenaline. We did have adrenaline ready, but not necessarily ready to be used or intended to be used right then and there. We optimized her ventilation through the vent, and we're managing really nice entitled CO2s, but we're quite aware of the potential shunt. She had a PA CO2 of 84, and we were getting entitles of 55. Whether that was because we helped blow off a little or not, we weren't sure, and didn't do another blood gas at that point to figure it out. But we're just happy that we were getting good chest rise. We could hear air entry into the bases of both lungs, and the patient's color and perfusion had all stabilized based on the ventilation. We optimized her position by getting her as comfortably head up as we could, with a pillow sort of just behind her head to hold it in the right position, and 1 or 2 pillows on the sides so that she didn't loll from either side once we were finished with the intubation. And I was obviously holding her airway throughout the entire pre-oxygenation process. We optimized the team, had a quick conversation about what the plan was. We were going to try a hyperangulated blade video-laryngoscope with the introducer inserted into a size 7.5 tube. We had a size 7 tube and a 6.5 prepared just in case. She did look like she was going to be quite a challenging airway. The decision was made that we would do that in the seated position, so standing behind the patient, and use the laryngoscope in the left hand as intended, with the video facing the intubator. The idea was that we didn't want to go from the front because she was already going to be quite challenging, and swapping hands was going to make it a bit uncomfortable for us. So that was plan A. Plan B was going back to ventilation with NIV because it had been working so nicely, and she was essentially partially paralyzed, even though we hadn't given a paralytic yet, simply because of the disease process. And so we were pretty confident that in that seated position we'd be able to get good chest rise again. We then decided that plan C would be an LMA, so we pulled out 2 appropriately sized supraglottic devices, one LMA and one eye gel, just so that we had some variation and some options, and BVM with mask was attached to oxygen and was sitting next to us. The fourth plan, if things went really badly, was to go to surgical crack. We were able to palpate the landmarks, but her neck was fairly short, and I wasn't comfortable that a surgical crack was going to necessarily be something that we would have to get to. But if we had to get to it, we were ready for it. We had the kit out, we had our equipment ready at the bedside. I had palpated the landmarks and decided not to mark them because they were very easy to palpate. And the plan was that if we needed to do a crack, we would flatten her immediately, pull her into a hyper-extension position with her airway, and my partner would be ready to cut. We then decided on some medications, so came to the decision, sort of initially we thought about preloading the patient with some fentanyl because her blood pressure was quite high and we were a bit concerned about raising cranial pressure as a possible complication. But once ventilation was sorted out and her perfusion state had sort of returned to normal, we weren't super worried about that, and we were a little bit more worried about dropping her blood pressure too much. And so our decision was we had fentanyl prepared, we had ketamine prepared, and we had rocuronium prepared. And the decision was to go with just a ketamine 2 milligram per kilogram based on ideal body weight, not based on her actual body weight. And then to give her a rock dose also based on ideal body weight, which we capped at 100 milligrams. The plan was then that we had somebody watching the SATs throughout the intubation attempt, and if the SATs were to drop below 85%, because that's sort of where we found her initially, then we would stop the intubation attempt and go straight back to NIV. That never ended up needing to happen, so that was really positive. And we also had the plan for the crack. My partner then gave medication, so we started out with ketamine and immediately followed by a rock and waited a full 70 seconds before we were ready to intubate. And I had hands on the jaw thrust the whole time, so could feel a loss of tone in her airway. Also noticed spontaneous breathing disappear at around the 70-second mark. Pulled off the NIV, immediately got the video-laryngoscope in, and this is the point where we'll move over to the video-laryngoscope video. Okay, as you can see, as we go into the airway, the very first problem is that the blade literally went between the tongue and the lower jaw, so into that sort of frenulum of the tongue. And this was quite difficult to see from behind the patient because the blade had kind of gone into the airway without being visualized going into the airway. So in the seated position, this is one of the risks, and that is that you can't actually see exactly where that blade goes. And the first rule of that video-laryngoscope is the first sort of quarter of the blade going into the mouth should be visualized with your eyes, not through the camera, because this is exactly what happens. And so my partner, who had been standing in front of the patient trying to assist at the time, said, I can see that the blade is between the tongue and the lower jaw, which then meant that I had to pull the blade out and start again, essentially, which did waste a few seconds of time, which luckily for this patient didn't translate into any kind of hypoxic episode. But if we hadn't pre-oxygenated and we didn't have the apneic oxygenation running at the time, that may have resulted in quite a quick desaturation, and we may have had to go straight back to NIV ventilation to try and keep the patient oxygenated while we replanned another approach. So that's sort of the first lesson, is just thinking about watching that first quarter of the blade move into the airway, past the tongue, and then making sure that you can sort of see the back of the tongue with your eyes, using it as a direct laryngoscope. And then once you've got that view, moving your eyes to the video so that you can see what's happening on the screen. And that's then what happened next. Managed to get the blade into the right spots in the airway. Managed to, you can see it just stick, sort of used as a Miller blade and scooping that epiglottis up. This is the second massive learning point, and you can see almost immediately I realized that the angle is not going to be right. And this is a lesson that you only learn when you play with the video-laryngoscope a lot, and that is that the bigger view, the broader view, is going to be much better than the closer view. So although the view that I had was a relatively good view, grade 2 to 1 view, Cormac-Lohan, it wasn't perfect for the video-laryngoscope because the challenge is getting the tube to pass into the cords when you don't have that perspective. So the very next step that I took was just to pull back with the blade so that we could get a much broader view, and you can see immediately the tube moves quite easily into that patient's airway. And you can see the whole epiglottis, you can see the retinoid cartilages pulling down to the bottom, and you can see the vocal cords just behind that. The next mistake, and it's insane how quickly these mistakes can line up on top of each other, but the next mistake that I made was when using the hyperangulated blade, you need to use the hyperangulated introducer, and the introducer is very rigid. It's not designed to be bent or changed. The idea is that it follows that hyperangulated blade perfectly so that it gives you the easiest insertion. The challenge with that is that as you get the tip of the tube into the airway, that that introducer sort of stops the tube from being able to advance. And so what you need to really do as you get the tip of the tube into the airway is pull back on the introducer about 1 centimeter or 2, just so that the soft part of the tube can advance into the airway. And then you sort of do a mixed movement where you're slowly pulling back on the introducer and slowly inserting the tube into the airway together, so that you never have the introducer really being that rigid kind of hockey stick vibe when the airway is sort of more flat once you get it up and into that upper airway. So you can see with the video what ended up happening is that we got the tip of the tube in, and I started pulling out the introducer, but actually pulled the introducer out too fast and then couldn't insert the rest of the tube. And so what then had to happen was I had to reintroduce the introducer as deep as it would allow me, and you can see it sort of happening now. And then I had to use the rigidity of that introducer with it not all the way to the tip, just to allow for that insertion. And that was then followed by removing the introducer and having the patient fully intubated. You'll also notice that the depth of the tube was quite intense, but we were just happy to have the tube in, and so it sort of went past that little black marking. And as soon as we started our assessment, we noticed that we were about 1 centimeter or 2 too deep, and immediately pulled back with the Untitled CO2 attached to the tube, making sure that we didn't lose the Untitled CO2 at any point, and so that we had much better air entry bilaterally. So in the space of a very short sort of airway approach, I think we're looking at 40 odd seconds. In 40 seconds, there are 4 errors that were made, and it's not the first time that I'm using the video-laryngoscope, teaching with it so often. So the first error was placing it not under visualization because of the angle standing behind the patient and not seeing it move into the frenulum space of the tongue. The second was getting too close to the upper airway and then having to pull back to get a bigger view. The third was inserting the tube into the airway but not explaining what my plan was, and so that introducer got pulled all the way out rather than just slowly as we inserted the tube. And then the very last one was inserting the tube too deeply for a patient. And all of these errors, luckily, don't end in patient negative outcomes, but definitely are learning points that we can share across the system. So the next time you pick up a video-laryngoscope, there should be 4 things that are in your mind. I need to watch that blade go into the mouth behind the tongue until at least 1/4 of that blade is in the airway, and I can see the base of the tongue. I need to make sure that I don't go too close. So getting that first visualization is fine to go close, but then pull back and give yourself the stadium view, the big picture. Remember that if you're using the hyperangulated blade, you're going to need to pull out that introducer slowly, sort of centimeter by centimeter, allowing the tube to insert without the introducer at the tip. And the last one is don't celebrate too early and insert too deep. Allow the tube to go to the right depth, pull back, and then reassess it immediately.